We live? Okay. Okay. Hello, everybody. Welcome to the December 19th, 2022 Health and Human Services Committee meeting. Let's just dive right in. First thing is changes to the agenda. We do have one additional resolution. I'm calling it the IRMA resolution, ERMA. That should be on everyone's desk. And then we have a revised version of a different one, which we'll get to later on. I'm going to propose that we insert the IRMA resolution at number 9.5 on this agenda. So we'll do it after all the other resolutions, but before the departmental updates. Next up is public comment. Do we have anybody on Zoom that was going to make a comment? Nobody on the screen that wants to comment? You're talking about Samantha?
Yep.
No, I'm sorry, members of the public? No. And Teresa, you're not up for, okay. No members of the public then. Chair's report, just have a couple little things to mention. First of all, just a few minutes ago, I got an email from Frank Krupa, Health Department Director. He will not be at today's meeting. He has the flu. So there was something he was going to discuss with us today, so we can either follow that up by email or he can come speak at our next meeting, whatever we would prefer. And then the other thing I want to mention is that our January date for this committee meeting is January 16th, which is Martin Luther King Day, which means we're not going to meet that day. And so we need to reschedule. And if you will look back through your emails later on, you will see something from Doodle. I think it was like last Friday maybe or something like that. And that's to reschedule this committee meeting. So go ahead and check for that. And I'll just mention what the dates were. They were possible dates to meet. Thursday, January 12th, Friday, January 13th, Tuesday, January 17th, and they're at various times. So please go ahead and check your email after this meeting.
And when I pulled it open, the times were all messed up, is all.
That happened to me too. Yeah.
Like
okay.
5 o'clock in the morning.
We'll send out a new email. Yeah. We'll start fresh. Okay. Yes, I had the same thing. It said 5 a.m. to 7 a.m. I was like, I'm not getting up that early. Okay. All right. We'll start again then fresh. Very good. So go ahead and look for that sometime after this meeting. Next up is County Administrator's Report. Lisa Holmes, hello.
Hi, thanks, Dan. Just a brief update on my end. I wanted to speak about the Human Services building security implementation is moving along. We are contracting with AMRIC Security Services, and there was just a meeting of the multiple Human Services building departments along with AMRIC facilities, Department of Emergency Response, and the sheriff on Friday to talk through some of the implementation details, and further meetings will be occurring, and the magnetometer is on order. So that is moving along. And then secondly, I wanted to make you aware that we will be hosting interviews for finalist candidates for Deputy County Administrator this week, this Friday. So our stalwart interview panel will be convening again. They're made up of legislators and department heads and county administration staff to do those interviews. So keep your fingers crossed. And that's it for me.
Thank you, Lisa. Any questions? All right, thanks. Okay, today we're going to have a presentation from Samantha Stevenson from Reach Medical. Reach Medical is an organization that I hear about a lot. I think a lot of us hear about a lot. And I've kind of learned about them in bits and pieces, and I think there's a lot more I don't even know. So I asked them to come here today to talk about what they do, and I asked to be kind of broad overview, so the kinds of programs they do, what their presence is in the community, And so here is Samantha Stevenson. Hello, Samantha.
Hi. Let me make sure. I'm, of course, transitioning to a new computer. So if anything, can everybody hear me okay?
Yes, but if you can hang on one second. Rob, can we get the lights changed a little bit so we can see a little better?
I'm envisioning my face on a giant screen in there, and if that's the case, just don't tell me.
Your face is medium on that screen, so you're good.
Okay, okay, we can work with that, I guess.
Okay, you're on.
Okay, great. Can I share my screen to present
Yes, please.
that? Okay, let me. Can everyone see that?
Yes, thank you.
Okay, great. My name is Samantha Stevenson. I am the Director of Operations at Reach Medical. I'm presenting today along with one of our many amazing physicians at Reach, Dr. Judy Griffin, who, Judy, do you want to introduce yourself now?
Sure. Thanks, Sam. Yeah, thank you so much for the opportunity to be here today to talk more about our work at Reach. My name is Judy Griffin. I'm a board-certified general internal medicine physician as well as addiction medicine physician at Reach Medical. I'm also the director of research at Reach, and I am a core faculty member at the Cayuga Medical Center Internal Medicine Residency Program, as well as the program director of the Rural Health Equity Training Collaborative, which is a primary care training and enhancement federally funded program that's a collaboration between Cayuga Medical Center, Reach, and TC3 nursing program. So it's a privilege to be here today.
Thanks, Judy. I thought that both of us, and so the presentation actually holds more information than I think is needed here. Our intention was just to add it all, let everybody have a copy of the information and leave our contact information at the end in case there were any questions. We're going to try to keep it to around 10 minutes and really talk about, there's a lot of integrated services that Reach offers in-house and telemed and through kind of outreach stuff and a lot of grant fund initiatives that we're going, that we kind of always have going on. But I'm going to try to focus specifically on Tompkins County, what our numbers are in Tompkins County, how many unique patients we have, and why we do what we do. I think for many folks who don't know data and evidence around addiction medicine and evidence-based prescribing practices, sometimes there can be confusion or even controversy. So I'm hoping that Judy and I can answer questions and kind of just give a clear picture of our presence in the community. So Reach opened, we formed legal entities, we're a nonprofit in 2017. We opened our doors in February of 2018, so we're coming up on our 5-year anniversary, which is exciting. Reach stands for Respectful, Equitable Access to Compassionate Healthcare. We're of course, a nonprofit, but we're very mission-driven in health equity. We're trying to give access to good healthcare to everybody, specifically marginalized populations that historically have not had access to good health care, especially equal access. We're a harm reduction facility. It's low threshold. We remove barriers to care. Here are some of our integrated services. So we have a big MAT or MOUD panel in Tompkins County. We serve just above 1,800 unique patients alone in MAT. So we have just above 1,800 patients in Tompkins County on Suboxone or buprenorphine. We're also a primary and acute care facility. We offer Hep C and HIV testing and treatment. We're an OOP site, which stands for Opioid Overdose Prevention Program. We've been an OOP site since 2018 when we opened, and we average over 300 doses of Narcan dispersed into the community each month. So we put out a lot of Narcan each month. We have internal case management, we have lead case managers, we have addiction medicine consult services with Cayuga Medical Center, we have a full outreach team, and like boots on the ground day to day, we have clothing closets and donation centers, and we do daily food distribution too. And Judy, I think I'll hand it to you for some of the data here, and just let me know when you want me to move forward.
Great. So, and first, just to kind of highlight this piece about health equity, all of us working at Reach Medical are committed to health equity, and we work in the field of addiction, many of us, because we know people living with substance use disorders face tremendous barriers to accessing healthcare, and when they do access healthcare, frequently they receive substandard or inadequate care and services. And that's very clearly demonstrated in the health outcomes data. So when you look at New York State Medicaid beneficiaries, for example, who are receiving health care for conditions unrelated to their addiction, like diabetes, the health outcomes for people living with addiction are worse than any other single other kind of identifier, whether it's serious mental illness, their housing status, their race or ethnicity. Having a substance use disorder leads to the biggest health disparity. So it's really a health equity issue. If we go to the next slide, I think many people are familiar with the staggering numbers of drug overdoses that we're experiencing nationwide. The most recent annual count exceeded 100,000 deaths from overdose related deaths. And that has really skyrocketed during the pandemic back in 2019. And you can see a little dip, in particular in that orange curve on the top. We had sort of like attempted to flatten the curve, and starting in April 2020, the number of overdose deaths pretty much increased across our community, across New York State and nationwide, with a 15% increase between 2020 and 2021, following a 30% increase between 2019 and 2020. And on the next slide, these numbers show, if you go to the next, these deaths are driven by fentanyl largely. Looks like Sam may have dropped off for me. I don't know if that's true for others. I can share my screen if that's the case. Yeah, let me share my screen. I have the slides also then. Are you guys able
Yes, we see that
to see
now.
these slides?
Yes.
Okay, great.
It's a really great time for me to lose an internet connection. Perfect.
Well, luckily we have teamwork. And fentanyl is driving these deaths. That's the point here. In the United States, we have the highest rate of overdose or drug-related deaths in the world compared to all other countries that keep track of numbers, and these numbers are per million residents. And at the same time, we have the least access to treatment. So whereas we have the highest death rates, only 11% of people in the United States with a diagnosis of opioid use disorder have access to evidence-based treatment, which I can talk more about. And this is largely due to barriers, structural barriers, stigma, and policy decisions. Locally, our numbers mirror the national trends, which showed a decrease in the number of deaths leading into the pandemic. And then, unfortunately, we're seeing these numbers increase every year during the pandemic, and we anticipate similarly high numbers based on what we've seen in 2022 also. But what we know, and I don't want to say silver lining because, very little is positive about this, but with opioids in particularly, we have really effective treatments. A lot of people are surprised to hear that, and many people don't know about that. So one of my main messages to you today and to every audience I speak to is there is hope, and we have effective treatments that are safe, have decades of scientific research supporting them, and we need to expand access to treatment, essentially, to prevent overdose deaths. So this is just one of many studies that have been published for the past 3 decades looking at medication for opioid use disorder compared to other treatment pathways. So one thing that people may ask is, why don't you send everyone to rehab or to detox or to these other treatment pathways? And that's just because it hasn't been shown to be effective. So this is a study published in JAMA in 2020. JAMA is one of the premier medical journals published by Sarah Wakeman, who's a professor at Harvard, and she looked at 40,000 adults living with opioid use disorder and just looked at what happened to them. She followed their pathways, and only 13% of the patients received buprenorphine, which is the medication we prescribe at REACH, which is Suboxone, and methadone, which is available in our community at CARS. So her numbers mirrored these national numbers of 11 to 13% of people receiving medication. And the outcomes she was looking at are overdose and at 3 months, and acute care, which basically means getting rehospitalized. And the outcome for overdose was that for patients receiving buprenorphine or methadone, there was an 80% reduction in overdose rate and a 30% reduction in rehospitalization. And if you compare these to the other outcomes, nothing else is effective. So that's really the basis of what we're doing at REACH. There have been countless randomized clinical trials and meta-analyses, including hundreds of thousands of patients, showing that methadone and buprenorphine reduce mortality from opioids by anywhere from 50 to 80%. They're safe, they're effective, and we know that they work. And how does our model of care, which is really a chronic disease management model, compared to a more traditional treatment model rooted in short-term care, acute care only, and detox? And what we're seeing is that in our model of care, this is really viewing substance use disorder or addiction through the long-term lens. We know these are chronic, complex, relapsing, remitting conditions that are rarely cured with one short-term treatment like detox or rehab. We don't take an abstinence-only or a cure-based model because that's not consistent with our medical understanding of addiction. In fact, this is borne out in studies. This study looked at whether or not detox was effective and the outcomes for patients that undergo detox. And 83% of patients had relapsed at 30 days. And with each additional pass through detox, the likelihood of achieving abstinence goes down for people. So it's not effective for most, and it's increasingly less likely to succeed over time. And this is a randomized clinical trial that was conducted. It's the highest quality form of medical study. And it compared patients on buprenorphine maintenance. They showed in their study about a 75% retention rate, which is very consistent with our experience at REACH, as well as a 75% abstinence rate. And they compared to this people undergoing detox. And over time, 0% of people undergoing detox were retained in care, and very, very disturbingly, 20% of people in that cohort died. So this data, this information, which is at this point decades old, informs our model of care. And we know this model of care is cost effective as well. This was a study looking at outcomes for patients initiated onto what's called MOUD, also known as MAT. And not only were patients who are linked to care on an ongoing basis, similar to the type of care we provide at REACH, those patients had the lowest healthcare costs. So that's something that's really critical to be aware of as well. And I'll happy to answer any questions about the literature, but we'll pass it back to Sam.
Thanks, Judy. So all of the information was kind of a precursor to just explaining why we're doing what we're doing and the evidence around that. So I think I'll go to, Judy, can you go to the, yeah, and then the next one. So when COVID hit, this one's perfect. It changed the regs around how we were able to prescribe for buprenorphine. Pre-COVID, we had to see all of these people face to face before any prescribers could initiate treatment, which was a big barrier because of transportation reasons, mobility reasons, just a number of things. So actually, with these regulatory changes, it was a huge barrier eliminator for access to care because we were able to start providing telemedicine services. Judy, can you go to the next slide? Our telemedicine has led us to have that number of around 1,800 unique patients on buprenorphine in Tompkins County alone. Next slide. It also allowed us to create an outreach team. Our outreach team consists of community health workers and RNs. We go out 5 days a week to the local encampments. We visit people in their tents and structures. We go to St. John's. We visit all of the contracted hotels and motels locally. We work in tandem with REACH and our multidisciplinary teams, making sure everybody has their basic needs met out in the community. Next slide. And one of the biggest outcomes here is our vaccination initiatives. Through the entire pandemic, we offered COVID testing, and then when the vaccines became available for COVID and monkeypox, we mobilized those vaccines. So during the pandemic, we were able to administer 370 COVID vaccines on foot to people who were experiencing unstable housing or homelessness in Tompkins County. And an interesting thing here is in the beginning of the pandemic, there were actually more Hep A positive cases out in the encampments than there were COVID. So we were able to work with people through that, keep them out of the hospital as much as possible, vaccinate the population of people that we knew were experiencing homelessness with Hep A and B, and then move towards COVID. So our goal really in this outreach work is being that medical support piece, and in addition to the other outreach services that have been available in our community. Next slide. So just quickly talking about the impact on public health with our outreach services. In particular, it's, we follow these trends in wounds and how they present because these tend to be patients that don't go to the hospital for a multitude of reasons, and our goal is to keep them out of the hospital anyway, and to prevent a bad outcome in the first place. So as the composition of the drugs that people are using change, the effects on the body change. So we see wounds presenting in different ways. We have, frequent meetings about that. And of course, with things like xylazine being introduced into the community, we talk about our overdose response changes and things like that. And then the more common in people who are using drugs and or experiencing and blood draws. So that's been a big piece of our outreach services. You can just skip through here, I think, Judy. We have behavioral health. It's fully integrated and on demand. We do also follow a evidence-based model around behavioral health, which is we don't mandate behavioral health treatment as it can be as it's been proven to be re-traumatizing. It's patient-driven and led, and it's on demand. So when people, if there are any crises with our patients during regular business hours, we field that right on the spot. Next slide. We also house the lead case managers in the LEAD initiative. I see Travis Brooks there, so I'm sure that everybody's familiar with LEAD. Next slide. And these are, I think these are things that we included as part of our research and program evaluation. Judy, I don't know if you want to touch on these or not, or they can just be made available to everyone.
Yeah, just to say we partner with researchers from Weill Cornell Medicine, NYU, and other institutions to study our approach. We've published 4 papers so far in peer-reviewed medical journals about our experiences that have, are becoming widely cited because really at REACH, we're doing the kind of integrated low barrier care for people with opioid use disorder that is essentially, innovative at a national level. And we're also doing a lot of teaching and training because we know healthcare workers, doctors, nurses, and others, PAs and NPs receive very little training on addiction medicine. And we have this expertise on delivering the care. We're able to provide enhanced training and education to nursing students from TC3 who rotate with us at REACH. from the New PACE program at Ithaca College. Students will be rotating with us, and the Cuga Medical Center residents as well.
Of course, we have challenges because over 80% of our patients are Medicaid patients, so they're underinsured. It makes financial viability a little bit tricky for us to put all the pieces together. And then just the fear and stigma around Suboxone, around the low threshold prescribing, the evidence-based prescribing, I think can lead to a lot of different kind of preconceived notions that people have, right? Because we think about abstinence being the only answer, Suboxone, like trading one drug for another drug. So we work hard to try and clear up language like that and thoughts like that and just deliver kind of the evidence and facts around that. And I think that's it. And we'll share these slides so everyone has access to them, and both of our contact information is present if any questions come up. Thank you so much.
Thank you. Let's see if we have some questions right now or comments. Randy.
Yes, thank you for the presentation. A lot to take in, and I have a lot of questions, but I won't toss them all out there. Narcan supplies, is Narcan readily available, or are you any concerns with supply of it?
We're an OOP site, so we order our Narcan supply directly from New York State. I haven't heard of any supply issues. We've never experienced any supply issues.
Good, thank you.
I place orders, every few weeks, I would say.
I think he's buprenorphine, is that how it's said? Can you talk about that a little bit? Is it basically a derivative of morphine, or what is that?
It is a semi-synthetic opioid, so it's not a direct morphine derivative, but it's an opioid-like medication. It's a partial opioid agonist, which means it binds at the mu opioid receptors in the nervous system, just like morphine would, or heroin or fentanyl. And it actually has a stronger affinity for the opioid receptors than any other opioid. So if someone has heroin in their system and we administer Suboxone, the Suboxone's stronger than the heroin, is going to displace the heroin. And it has a partial activation. And the reason it's so effective is because of this partial activation. So it reduces cravings, and it eliminates cravings and withdrawal symptoms for opioids, which are powerful drivers of ongoing use. And at the same time, it's safe because it doesn't cause respiratory suppression, which is the mechanism of death in opioid overdose. So it's safe and effective. And the reason it's better than an opioid antagonist medications like naltrexone, which is also called Vivitrol, is that Vivitrol is a blocker. So it doesn't control cravings in the long term. And you see really low retention rates among patients on Vivitrol compared to buprenorphine or methadone. And when we look at mortality benefit, only methadone and buprenorphine have been shown to reduce mortality compared to Vivitrol, which hasn't.
Is this a daily treatment?
So it's a daily medication. And so as a primary care provider, I prescribe buprenorphine similar to how I'd prescribe a medication for diabetes or high blood pressure. So I see a patient, evaluate them, note any side effects or symptoms we're managing, send a prescription via e-prescribe to a pharmacy, a community-based pharmacy, CVS, Wegmans, Kinney. The patient can then go pick up their prescription. And because of the scheduling of buprenorphine, we're allowed to put refills on that. So it's similar to, getting a prescription for high blood pressure medication. That's distinct from methadone. Methadone for opioid use disorder can only be prescribed and dispensed at what are called opioid treatment programs, or OTPs. Those are federally regulated entities where people actually go in person, in some cases 6 days a week, to get dosed. But buprenorphine is heavily regulated compared to other opioids. As a primary care doctor, I could prescribe as much oxycodone essentially as I wanted to, as many patients as I need, was seeing. With buprenorphine, even though I'm board certified in addiction medicine, I can only treat up to 275 patients per month. And just by comparison, if I were seeing general medical patients, a regular primary care doctor would have, over 1,000 patients. So it's very limited based on those policy restrictions.
Okay, and lastly, your data doesn't include any alcoholism or alcohol abuse, or does it?
I was presenting information about opioids because, that's primarily what we're treating. Alcohol use disorder, there are effective medications for alcohol use disorder, but I don't know if I'm inferring here about the question about detox. I don't know if that's what your question relates to in any way.
I was just curious about the data, if it included it. That's fine. You don't have to go any further.
This is just opioid data.
Okay, thank you.
Mike?
Well, I was just wondering, from the presentation, it almost seemed, not almost seemed, it seemed like you were saying that at least for opioids, detox just isn't there's no reason to do detox. There's no reason to have one. We should just go this other direction.
So what we see for opioids in particular is that detox puts people at risk because tolerance plays such a huge role and relapse rates are so high. And so in the community, what we found treating thousands of people at REACH is that people can safely transition onto the medication without going to detox. That's what our experience is clinically, and that's what the research supports.
Now, do you ever?
And go ahead. Sorry.
How long till you then transition off the medication, or do you not transition off the medication? So,
I always use the analogy of diabetes. So if someone is found to have diabetes, we will, in the vast majority of cases, we'll prescribe medications to them, especially if they have, insulin-dependent diabetes. Some patients with aggressive lifestyle modifications are able to reduce their medications over time, or their high blood pressure medications. So the same is true for buprenorphine. So I have patients who have been on buprenorphine treatment for over 10 years. It's only been FDA approved since 2002. So that in the United States, it's been prescribed in Europe since the 70s. But we see decades of data that support long-term maintenance. And we know about up to 90% of people who taper off the medication will return to use of other opioids. So we're really talking about a life-saving medication that's safe and effective, that withholding that medication puts someone's life at risk because opioid use disorder is a life-threatening condition. And we have this medication that really works, not 100%, doesn't work 100% of the time, and it's a chronic disease. So people can experience ups and downs with their condition, but we can work with them because we're not an abstinence-only based organization. Look, most of our patients are abstinent. That's what they want for their lives and themselves. But for people that relapse, they know that their treatment won't be discontinued and they won't face punitive or even criminalized responses for their substance use or their relapse of their chronic condition, and therefore we can get them the care they need over time.
Any other questions or comments? Veronica?
Yeah, maybe just a small curiosity question, but I saw the acronyms MOUD and MAT in there for medication treatment. Are those the same thing?
They do refer to the same thing. MOUD is now the preferred term, medications for opioid use disorder, and it refers to buprenorphine, methadone, and naltrexone. MAT is a term that originally stood for medication-assisted treatment. So this came from the idea that what people really need is counseling, but we can give them medicines which will also help. And based on science, we know that medications are the treatment. And many patients benefit from counseling. Up to 50% of our patients receive counseling. It's just not mandated in order to receive medical treatment. So you'll still see both terms. And MAT is still widely used. So medication-assisted treatment, I think it even was medication-assisted therapy in the beginning, and then medication-assisted treatment. And now you'll see medication addiction treatment also, as the term.
And then one more question. I've heard from, some people in the community a desire for a detox center here, and I hear you saying that doesn't work with me. Go ahead.
Yeah, no, I appreciate that, and we are not opposing. I'm presenting scientific evidence. That is the purpose of what I'm doing. I strongly believe in people accessing care voluntarily that they want to do. If I had, say, a friend or family, they were asking me, so-and-so has an opioid use disorder, should they go to detox? I would just probably give them information in my medical opinion. There are other substances that people use, including alcohol, that can require medically supervised detox that is appropriate. I think people want safe spaces to transition off substances, and we don't provide a lot of options for that. So detox is viewed as one option, and a lot of times our patients are facing tough choices, like, do you want to go to prison or do you want to go to detox? So that is frequently also a scenario in which people will express interest in that type of treatment.
Thank you. This is the last part. The part of the question would be if, based on your research and direct experience, what thing outside of the scope of REACH would be helpful to have in this community to, maybe it's not a detox center, but is there something that comes up a lot?
I think that supportive housing in a housing first model is sort of a complementary service to harm reduction services and low threshold medical care. So along with case management. So intensive case management is an evidence-based practice that has been studied in different clinical settings and has been shown to be really effective for these complex cases that involve frequently mental health, substance use, and the social determinants of health, things like housing insecurity or homelessness, criminal legal contact, things like that. So intensive case management, supportive housing. What would you say, Sam?
I would agree. I think that we have to move towards really thinking about housing as part of healthcare and kind of like a script for housing, right? Like, this is where this person is in their use disorder or their mental health, or a combination of the two, and moving towards true supportive housing with different framework than the traditional low-income housing has had.
Mike?
I guess my last question is, what is the biggest, if you're thinking of these different medications almost like insulin, whereas these people that have this addiction issue will be on forever, what is the barrier to us getting them that medication on that kind of a schedule, almost like on an insulin kind of schedule?
I would say the biggest barrier remains stigma. And so there's a widespread belief, that addiction is a choice and a moral failing, and that type of view of addiction informs how people engage with treatment. And so people are very ashamed to be on Suboxone. People face discrimination if they're on Suboxone when they go to the pharmacy to pick up their prescription. They're often face barriers. If they go to get other health care, being on Suboxone will mark them in ways that discourage people from starting or remaining on treatment. So that's to me the biggest barrier is stigma. But then there are policy and regulatory barriers, including the policies around the prescribing limits, the number of people that I can treat with Suboxone. I know the federal government is reviewing a bill, I believe it's called the MAT expansion bill, that the Biden administration is promoting, that we strongly support, and so stigma and policy, and then health insurance, making sure everyone in our community has access to health insurance. Obviously we have low rates of uninsured compared to other states in New York because of Medicaid expansion and other policies. So that's great, but we should continue to do more of that.
Thanks.
I had a couple of questions. I just want to make sure I heard this correctly. 1,800 Suboxone patients in Tompkins County, is that accurate? that what you said?
That's correct. Yeah. That number is actually from September, so it's probably a little bit higher.
Can you talk about, in a general way, how Suboxone patients function in society? Is it easy to sort of hold a job and do the things that, I don't know, that I do?
It's a life-transforming medication in that it just eliminates opioid withdrawal and cravings for the vast majority of our patients in ways that normalize their physical and emotional existence and really feeling normal is our therapeutic goal. And it's sort of the metric we go for with our patients. The recoveries people can achieve are astounding. I have patients who are nurses in ICUs who are working in business and every other walk of life, like all walks of life. It's very transformative no matter where someone's at. It does not cause sedation, euphoria, intoxication, and it doesn't put someone at risk for overdose. In fact, it lowers their risk dramatically. So it's safe and effective. I would, in a medical terms, it's safer than being on a blood thinner. It's safer than being on insulin. It's much safer than these other medications that we routinely prescribe.
And that's a great question because I think it hits on the stigma piece. When people think about people who take Suboxone, I think oftentimes the thought is directed towards people that are actively injecting drugs. And it's not a thought around all of the millions and millions of people who are living fulfilling, safe lives on a stabilizing medication.
Thank you. My last question, roughly how many employees does REACH have?
We have just under 50 employees. I think this is HR, but I think it's around 43, 44.
Okay. Thank you. Randy.
Yeah, thank you for the discussion. This is very helpful. Can you say about what a prescription would cost for somebody that does not have insurance?
So it's a huge, on the order of hundreds of dollars per month for people without insurance. There is kind of a workaround that we have, which is there's another brand name buprenorphine product, not Suboxone. It's called Zubsolv. It's still buprenorphine. And that company provides coupons for up to, I believe, at least 30 days, if not 2 30-day prescriptions. So if patients are in some sort of lapse of their insurance, we can get them that medication. Otherwise, they're paying out of pocket, on the order of hundreds of dollars.
Great, thank you.
I want to thank you very much for coming and talking with us today. It's very impressive, the work you're doing and the information that you're basing your work on. And I'm really glad you're in our community doing this stuff, and I learned a lot today. And any last words you want to say?
I'll just say thank you so much for taking the time to hear about our work and giving us this opportunity, and for your support.
I agree. Thank you so much. And feel free to contact either Judy or myself if any questions come up after you review the slides or otherwise.
Excellent. Thank you.
Thank you.
Right. We are going to continue on our agenda. As I've mentioned already, our health department director is not here, so we're going to skip that category unless someone has something to say. Okay. Next up is Department of Social Services. Kip Kephart is here. Hello, Kip.
Hi.
And can we have one resolution from you? Budget adjustment, social services.
Yes, so this is a budget adjustment for social services for the scheduled replacement of a portion of our fleet, our vehicle fleet in 2022. The total cost of the electric hybrid vehicles that were recommended as purchases by the Green Fleet Capital Program just exceeded the social services appropriation line by $22,632. So this is just a budget adjustment that corrects for allowing our maintenance of the social services fleet necessary for providing services.
Thank you. Somebody want to move that? Travis moves, Veronica seconds. Any discussion? Okay, let's have a vote. All in favor? That is unanimous. Thank you. Kit, anything else you want to tell us this month?
I'm sorry, Dan, did you say just check in?
Yeah, any other report you want to give?
I just, I guess the only things right now that I can probably give a report on here near the end of the year is we continue to struggle somewhat with staffing, but I think we're seeing a little bit of light through the clouds there. We've still got between 10 and 12 vacancies for the department, but I think we are starting to see a little bit of improvement. So I'm hopeful that we may be able to get some positions filled. We're seeing our homeless numbers hang in there pretty steady, around 175 people in shelter. And typically the largest majority of those have applied for THA support, about 125 typically, and the other 50 are our code blue. So that's, we like to see the majority having applied for THA. We can do a lot more for people when they have made application through that program. So that's kind of where we're at as we wrap up the end of the year. I don't think I have anything else right at the moment to report. Thank you.
Questions or comments for Kit? All right, well, thank you.
Thanks.
Next up, Office for the Aging, Lisa Monroe. Hello.
Hi there, how are you?
Good, how are you doing?
Good.
Let's see, we have one resolution from you, budget adjustment, Tompkins County Office for the Aging, unmet needs. Somebody want to move that and put it on the floor? Veronica moves, Travis seconds. Thank you. Lisa, anything you want to tell us about this one?
It's just strictly a budget adjustment, just putting the money in the right places so we can expend the funds in alignment with our state annual plan.
Any discussion on this resolution? Ready to vote then? All in favor? That is unanimous. Thank you. And Lisa, is there anything else that you'd like to tell us about?
No, I don't have a report today. Thank you.
Okay. Well, thank you. Next up, oh, sorry, Randy.
I don't know if this is for Lisa or not, but when we met last week, I think it was last week, Veronica, were there, you mentioned participation in SNAP, and maybe Kit could answer this question as well. Maybe it goes to her. What percentage of the people that actually qualify for SNAP are actually getting it in Tompkins County? Do we know that?
Well, so it's a little bit hard to, so I want to make sure I understand, Randy, the persons that qualify for SNAP that we know about are people that have applied. So I don't have a way to tell you of all the people that might be out there in the community. Is that what you're asking, that would qualify for SNAP but maybe are not receiving it? Is that what you're asking?
I'm curious, once it just, I was just thinking there might be some number of people, a large number, that do qualify but just never apply for it. So that was my question.
So that number may be available out there by someone who's calculated it. It's not a number that I have available to me. SNAP is not a program of, it is a program of application. So in other words, you have to come in and apply for it. It's not a program that we can go knock on a door and say, would you like it? So I don't have a way to know who might be out there in the community that would be eligible but hasn't come in to apply. And those that come in and apply, we certainly make that accessible to them. Does that make sense?
It does. It does. And I knew it would be a tough question, so no, don't feel bad about it.
There was a study done in 18 or 19 by, I want to say, Healthy Food for All, that initiative, and it was 35% of eligible folks were actually getting SNAP benefits in the county. So I think it's an estimate of like $30 million was being left on the table that could go into the local economy because of that.
That's all federal funds, correct? All SNAP money is federal funds, or?
It is a federal program of the FDA. Yes. Yep.
Great. Thank you.
I can just add to Randy that, a lot of times we have people that we identify that they're eligible through other programs, and we assist them in filling out those applications, because sometimes people just don't know it until they're in the situation where they have to apply for it, and we can help them apply for it too.
Thank you.
Mm-hmm.
Any other questions or comments for Lisa? Okay. Thank you, Lisa.
Thank you.
All right. So next up is the resolution that we added. So again, that should be on your desks. And it is authorizing Tompkins County to participate in the Equitable Retention Mortgage Assistance Program. Does somebody want to move that? Randy moves. Mike seconds.
I can speak
Lisa,
to it, Dan, if you're...
Yep, please.
Okay. This program came to my attention through Betsy Wall from Law New York. She called our office last week informing us of this program, which is an opt-in program through the New York State Attorney General's office. Counties can opt in to apply for it, and or to just make older adults in our community eligible, or make this an option for people in our community at no cost or obligation to the county. It's basically a program designed to prevent foreclosure for people age 62 and over in the form of deferred forgivable loans. And she said she actually had a client through Law New York that would be eligible if we were able to offer this in Tompkins County. So we looked into it a little bit more. It does not seem to be, there's no downside to our joining.
Yeah, I also, when I heard about it, I think it was just on Friday, I just Googled it, I'd never heard it myself, because it sounds a little too good to be true, and it kind of is, as far as I can tell. It's an excellent program. I'd say the one thing that I noticed is in order to apply, you have to supply a lot of information, a lot of documents. So it's not, what do I want to say, somebody either has to be pretty sharp or get some assistance, but that's not a criticism of the program. I'm just saying it's not an easy application, but that's okay. Any other discussion about this resolution? Okay, let's have a vote then. All in favor? That is unanimous. Thank you, everybody.
Thank you for taking action on it on short notice. Appreciate it.
Yeah, thanks for bringing it to our attention. So let's see. Next on the agenda is department updates, and then we still have another resolution to get to after that. So let's see. How about Kate Shanks Booth, County Youth Services?
Yes, good afternoon, everyone. Not a whole lot going on here. We're just closing up into the year, getting ready to switch over in 2023, working with our municipalities to make sure all the youth commission stuff is closed up, and also getting ready and planning for 2023. And so that is really what we're working on right now.
Any questions for Kate?
Hey, Kate, I was wondering, what do you have new planned for 2023?
I'm sorry, can you repeat that?
What do you all have new planned for 2023? Is there any new initiatives coming out in 23?
Well, I don't necessarily know that they're new initiatives, but we are going to continue to work with CSEC. We're going to be targeting our libraries and our municipal youth commissions to make sure that we're getting safe harbor information in CSEC out to the more rural communities. We're going to continue to focus on our runaway and homeless youth program and making sure we're getting that information into the hands of youth and families that need it. We launched a new youth commission in Danby in 2022. So we're continuing to strengthen that and work with that. And we'll be opening, we're really excited, a new youth commission in Newfield in 2023. So that will be expanding. And so we're going to continue to work and just meet the needs youth in the rural areas. It seems to be a real area of focus. Continue to work to strengthen our funded agencies. We're really also working with our youth advisory board to make sure that we're bringing in information, not just from our funded agencies, but also agencies that are doing work with youth that may be doing with new trends, focusing on mental health, and bringing and make sure that we're aware and that the decisions that we're making are informed by the things in a holistic, larger picture fashion. So.
Kate, is your department fully staffed?
We have 3 of 4 right now. We have an administrative assistant position that is open. Teresa Albert moved from that position to the deputy director, and so we were waiting to fill that until after January, and also looking at ways to maybe use that individual in different capacities in the department to make sure that we were being as effective and efficient with tax dollars as we could be.
Thank you. All right. Thanks, Kate.
Yep.
Next up, J.R. Claiborne, Veteran Services.
All right. Good afternoon, everyone.
Good afternoon.
All right. Kind of like Kate said, everything is getting ready for the end of the year. But I guess the main things is Warrior Riders. I've talked about them before, but we've restarted. We've got a new night now, the second and fourth Tuesdays. And my bigger focus this past week and going beyond will be focused on hiring 2 positions that you all have granted me for providing services to our veterans. And this is actually going to be really great timing because in addition to the increasing flow that I'm already seeing, the VA has been doing a big push with the new PACT Act. And I expect to hear and more from our veterans community with that. And the PACT Act is the Sergeant First Class Heath Robinson honoring our promise to address comprehensive Toxics Act. So basically, it's a large expansion of the VA's healthcare and benefits program, and the expectations are that it is going to increase the eligibility for access. And this is for veterans who have experienced toxic or radiation exposures through the Vietnam War and our more recent 2 conflicts in the Middle East.
Thank you. Any questions or comments for J.R.? Randy?
Hello, JR. Any concerned about space for your new staff? Or?
We've got a plan for here in our Human Services Annex. And so that's right now, we're going to see how that's going to work. Yeah, and that's really the best we have right now. I think we're trying to shoehorn a department into a building that was already staffed with Office for the Aging. And they've been very gracious hosts. But noting every time I get to add somebody, it takes something away from them. So we're working with Lisa to find out the best way to balance that.
Great, thank you.
Yes, sir. I guess I should say the least painful way to balance it.
Yeah.
Okay, well, thank you, J.R.
Thank you, everyone. Happy holidays.
Next up, Ken Clark, Office of Human Rights.
Good afternoon. Just a short report from us. We held our 35th annual Human Rights K-12 Human Rights Arts Competition K-12 Awards Ceremony on December 10th. We moved the date back for the awards event back to International Human Rights Day after having done it the last 2 times. In connection with either the King Holiday or Black History Month. We were online, as we were a little earlier this year for the previous school year, and had some great submissions provided by students in a variety of ways through film and through poetry and through other artistic renderings. And we hope to be able to hold the event live in person in 2023. We had close to 70 attendees, students and families, teachers and staff from various schools. And so we will be beginning to think about, how we will conduct the competition for this upcoming year and encourage even further student participation. The other thing would be that The civic engagement initiative that OHR and the Human Rights Commission have spearheaded, it's called Your Voice, Your Vote, is now focused on defining its mission and looking at additional ways to engage our local public. Our initiative has garnered some interest from the League of Women Voters of Chemung and Steuben counties. We will be meeting with them and having a panel discussion with them on Saturday, January the 21st, to talk about our work and looking at ways in which we might be able to establish some ties with them. So those are, otherwise, you know, things are going well in the office. It's quieting down a little bit as it typically does around this time of the year.
Thank you. Questions or comments for Ken? All right. Well, thank you.
Welcome.
At this time, are there any other comments from committee members for liaison assignments and those reports? Okay. Then we have another resolution. This comes to us from committee member Randy Brown. Randy, do you want to introduce it?
Yes, this is a resolution for authorizing or urging the New York State governor and the legislature to adopt universal access to free meals for students in grades K through 12. Over COVID, that happened for all schools, and it was funded. But in June of this year, that will expire. So many schools that don't qualify for CEP, which is basically 40% or more of the students need to qualify for free or reduced lunch to receive, no charge lunches. And so this is urging the governor to just make lunch and breakfast free to all students, which would be in Tompkins County, all schools in the county, at least 30% of the students do qualify. So it's just under that threshold for this to happen. And all the studies show that kids that have decent food and get meals do better in all aspects of their life in school. And so this is just urging the governor to do this, and it states how much it would cost, about $200 million per year.
Thank you. And I believe you have a revised version that's not in our packet, that's on our desk today.
Correct.
So do you want to go ahead and move the revised version?
I do. I'd like to move the revised version, resolution number 11368.
Excellent. Thank you. Is there a second? Travis seconds. Discussion. So my only thing, Randy, I wonder if you want, it's not a biggie, but I was looking at I'm not sure what number whereas is, the bottom of page 1, and you list some schools. I wonder if we just wanted to tinker with the words a little bit. So it says, according to this organization data, for Tompkins County School Districts, TST BOCES, Newfield Central. Is it Newfield Central School District? Is that the?
Yes.
Okay. Enfield Elementary. Okay, so so it's not the entire Ithaca City School District, is that correct?
Correct. Only that particular one, and that's the way it lists them in the database.
Okay, so can we call it Enfield Elementary School?
Yes.
And then the next thing says Ithaca Beverly Martin. I think it's just Beverly Martin Elementary School, maybe, or Beverly J. Martin Elementary School. Is that okay, Randy?
Yes.
Okay.
Sorry about that.
That's okay. I'm just, it's no biggie. Might as well do it here. And then Dryden Central School District, is that maybe their name or?
Yep.
Okay.
I can change that. Okay.
That would be great. No biggies, right? And then what else? Oh, CEP. I just want to make sure. CEP, yes, that is defined there. Okay, that was my only little tinkerings. Any other discussion about this resolution? Mike?
I'm voting for it, and I support it. I just would like to say that the federal government should be paying for this and not the state. So,
I agree.
Any other discussion?
I actually went to a presentation. I think CCE put it on. No, it was actually the Park Foundation. And it was with all the school districts. And the person that was trying to, there was a few different things, but this particular presentation was on converting cafeterias in school districts to make fresh food rather than bringing food in that was pre-made from places. And the woman who was teaching doing the seminar runs food programs in California for their school district. And one of the things she talked about in California was because it's free for all, they were able to make these phenomenal changes within their cafeteria systems in the way they presented food. And it actually cost less to do food this way because they were cooking it from scratch. And not only did they bring the cost down, but kids were actually eating fresh foods, fresh vegetables, things that were cooked in-house. And it was pretty cool. But they credited the state doing this program to being able to do that across the state, which allowed them also to bring in food sources where they were supplying school districts all over, which brought the cost down. But I thought it was pretty cool. So when I saw this, thought this is pretty cool how it goes together.
Excellent. Thanks. Excuse me a sec. Just see someone out there. Okay.
Mail.
Okay, great, thank you. All right. So we have the motion on the floor. Any other discussion about it? The resolution is on the floor? No? Ready to vote then? All in favor? That is unanimous. Thank you.
Thank you.
Okay, thank you, Randy, for bringing this to us. Next up, appointments, advisory board appointments. Do we have some? Do we have advisory board appointments? Did I lose my attachment maybe? Does anybody have it handy? The advisory board appointments, mine fell off and thank you so much. Yes, that's why there was a little clip on my sheet and there's nothing clipped. I lost it somewhere along the way. All right, so here's what we got. Sulimar Peña Vasquez for the Community Mental Health Services Board. Elise Switzer for the Community Mental Health Services Board. Travis Winter for the Community Mental Health Services Board. And Allison Weiner Heineman for the Community Mental Health Services Board. Oh, we got more too, sorry. Jessica Connor and Dan Doyle, also for that board. And then I see Sulimar Peña Vasquez again. Not sure.
So the Community Mental Health Services Board is a board by itself, and then there are also subcommittees, and the appointment to the whole board and the subcommittees are just separate things.
Thank you, I'm seeing that now. Do I need to restate any of that for the record? No, it's all in there. So, right, thank you. The second Sulimar is for Substance Abuse Subcommittee. For the Human Rights Commission, Pei Soyinka Arwele. Forgive me if I have not said that very well. And for the Office for the Aging Advisory Committee, Carrie Shearer. So I'd like to move all those appointments, or is there a second? Randy, any discussion? Okay, let's have a vote. All in favor? That is unanimous. Thank you, everybody. Next up is minutes approval for the November minutes. Mike Sigler is moving. Travis is seconding. Any discussion on the minutes? Okay, let's have a vote. All in favor? That is unanimous. Thank you. Let's see. Is there any other business that we need to take care of today? I've got one tiny little thing. Last month, while we were meeting, we had a little technical glitch, and the thing was the feed was down for a few minutes. And I said, "Does anybody know any good Health and Human Services Committee jokes?" And nobody had any. So I went home and looked up some, and I found one that I think is pretty good, and it involves the HIPAA law. What's that? Privacy Protection Act or something like that? Okay. Knock, knock. HIPAA. Sorry, I can't tell you. And unless there's any other business, our meeting is adjourned. Thank you, everybody. Leave them laughing.
With that REACH presentation.
Recording